Good morning, everybody. Thank you for your patience. My name is Megan Williams, and I am the Director of Support Services at Alzheimer Group. January is Alzheimer's Awareness Month, and this year, as you know, AGI features a series of lectures to raise awareness and demystify the misconceptions of Alzheimer's and other forms of dementia. AGI supports people living with dementia and their families. Our services include online activities, counseling, education, and support for family caregivers. Today's lecture is made possible by the generous support of the Lasner Learning Center. AGI is a charitable organization, and we rely on support of donations. This is a free lecture, but you are welcome to donate at any time by calling us or visiting our website. Today's lecture, everyone will be on mute, and you can use the Q&A or the chat function below to ask any questions. At the end of the presentation, our outreach coordinator, or I will be reading your questions to Dr. Moussavi. For today's webinar, we have the privilege to present Dr. Zahra Moussavi, who will be speaking about early diagnosis and non-pharmaceutical interventions of Alzheimer's disease. Zahra Moussavi is a professor and the founder and former director of a biomedical engineering graduate program at University of Manitoba and a former Canada research chair. Her current research focuses on medical devices, instrumentation, and signal analysis for sleep apnea management and Alzheimer's diagnosis and treatment. She is currently the leader of the largest rTMS, excuse me if I mispronounced that, treatment clinical trials of Alzheimer's disease. She is a recipient of several awards, including the Technical Excellence Award from Engineering Geoscience Manitoba, Canada's Most Powerful Woman, Manitoba's Distinguished Woman, and she's given numerous outreach talks for the public, including 2 TED Talks. Wow, that is a mouthful. So without further ado, Dr. Moussavi, the floor is yours. You just have to unmute yourself.
Okay, good morning, everyone. I suppose you can hear me now, right?
Yeah, we can hear you.
Yeah, Megan, Nina, but at least you can put your video on. I need to see some faces to talk. I'm a teacher, don't forget. Usually in online teaching, all the students have to keep their videos on. Otherwise, it is so difficult to give a talk. Okay, without wasting any more of your time, let's start. The title, as it says, is about early diagnosis and interventions of Alzheimer's disease in general. So I may have to skip some slides a little bit faster to save the time. If there is any pressing question, you may, I don't know how you can let us know in today's topic. Can I see the raised hand or chat immediately? Anyway,
you can see it in the Q&R or in the chat. You see the questions there. And we will read the questions at the end for you.
Sure. Okay, I keep that window open to see if there is anything on the chat. Alzheimer's condition, as I usually say, it's a thief because it comes and steals the most precious memories that people identify themselves with. It is indeed a very clever thief because people who have Alzheimer's don't even know what they have lost. They just feel they are lost in time and space. So the question is, what happens in the brain of a person with dementia, in particular Alzheimer's? This picture on the left shows a healthy brain, on the right shows an advanced stage Alzheimer's. Keep in mind that it is a very, very advanced stage Alzheimer's post-mortem. So at earlier stages, probably nothing can be seen even by the MRI. That's why that the imaging are not so specific to diagnose Alzheimer's at the very onset. because normally by aging, we have some changes to our brain, and people at earliest stage of, very, very earliest stage of dementia, they have similar changes. But now we know by postmortem, by the advanced stage, what happens is that the cortex, the volume of the gray matter starts to decrease. Basically, some of the neurons are going to die, and therefore the volume decreases, and the shrinkage is especially very severe in hippocampus. Hippocampus is an area that is responsible for converting short-term memories to long-term memories. It is, if you want to know where it is located, it is below the cortex. It is basically 2 centimeters behind this nasal, and 5 centimeters deep from the surface of the skull. But if you design a probe that could go from the nose to the brain, you can reach hippocampus. By the way, you know that our skull has a number of windows to the brain, and nose is one of them. Ears are the other 2. We have a tympanic membrane, yes, but that still is considered like a window. And our eyes. Our eyes are also windows to the brain, and covered by a very thin retina. Otherwise, there is access to the brain. But the best access is through the nose, basically. And so in severe Alzheimer's, the ventricles, these areas, they become, they enlarge and fill with fluid. What we know so far about why it happens is that some proteins, everybody have heard about beta amyloid. Up to 10 years ago, everybody thought that it is only beta amyloid, that it is the culprit. But nowadays we know that beta amyloid is not really the bad guy. The bad guy is really the tau protein, that if the tau protein is excessive in the brain, we do have them, we need them. But if it is excessive, then beta amyloid start to bad behaving in the presence of the tau. And what they do is that they cover the neurons. Basically, they sit on the synaptic connection. Synapse means the connection between the neurons that they communicate with. And they cover it and eventually isolate the neuron. So they don't let a neuron communicate with the other neuron. This is shown in this picture a little bit better. On the left, it is a healthy one. On the right, it is showing neurofibrillary tangles. These synapses act like communication channels between two, like a phone and a receiver. And these tangles, as a result of tau protein, is basically destroying the communication channels. And you can see that if a neuron cannot communicate with the other neuron through its synaptic channels, then obviously we start to forget things and get to confusion. And one more thing is that eventually, if a neuron is totally isolated, eventually it will die, because our brain is an extremely efficient machine. It says that if a cell, including a neuron, doesn't do anything in the body, it says that why should I feed you? Go die. So basically, that's the mechanism of how the cells are governed in our body, how the neurons are governed in our body. If a neuron is isolated completely, it will die. As far as diagnosis of Alzheimer's and treatment, there are neurological examination, neurologists or neuropsychiatrists examination. They use a standard questionnaire, and there are some diagnostic aids. First of all, imaging. Everybody knows about that, MRI, PET, or even CT scan. We need imaging. However, the problem with imaging, as I said, is that at the very earliest stages, the imaging is not going to show us much. Basically, the imaging of age-matched people at all ages is very much similar to people with Alzheimer's. I'm talking about the onset of Alzheimer's, before even clinical symptom. So imaging is very good, but it doesn't have sensitivity, specificity to diagnose at the very earliest stage. There is a technique called TMS, paired pulse and latency. Some neurologists in Italy have started it, have developed it. It seems it is quite a good technique to distinguish vascular dementia from Alzheimer's. By the way, the term Alzheimer's and dementia, dementia is a general term. Alzheimer's is a specific type of dementia. Up to, again, 10 years ago, we thought that 75% of cases are Alzheimer's. Nowadays, we know that that is not true either. 75% probably are a mixed dementia. Alzheimer's is often mixed with some cerebrovascular dementia, and that adds to the challenge and difficulty of diagnosis. There are EEG brainwave recording for diagnosis, not very sensitive again. There is egocentric spatial orientation, which I use in my lab. It is my hypothesis, basically, I'm saying. I'll explain a little bit more. And there are Electro Vestibulography. This is a technology developed in Australia. Now we are running it in Manitoba. It is the only one in Canada. Laval University in Quebec is establishing the second EVSG lab in their laboratory as well. As for medication goes, there are a number of medicines like Aricept or donepezil, which is the best medication. And there are a number of other ones, more or less they're all acetylcholine inhibitors. And the point is that their efficacy is pretty low. Aricept is the most used medication for Alzheimer's, for dementia. Every single person with MCI even have maybe Aricept. In general, it is tolerable, except some people who cannot tolerate it, but its response rate is 1 in 42. So you can see that it is pretty low. The majority don't even respond positively. Non-pharmaceutical treatment include TACS, TDCS, that is short for transcranial direct or alternating current stimulation. I do it in my labs. There is light stimulation. I don't buy it that much. It is research stage, very early, but theoretically, I doubt it. There is transcranial electromagnetic stimulation, hyperbaric oxygen therapy, rTMS, and cognitive exercises, and so on. So medication in general, well, everybody uses it, but unfortunately, they are not very effective. And to discuss why they are not very effective, it is long. To give them the benefit credit for medication, it is not that they are not doing a good job. It is indeed very, very challenging to come up with a nervous system medication. I usually teach it in my brain course that why it is so challenging, but it is beyond the scope of this talk. As for non-pharmaceutical, as I said, there is rTMS treatment that we do in our labs. Montreal is one of our sites that is doing the clinical trial too. TDCS, TACS looks like this here. I think you can see my mouse. Daily cognitive exercises, transcranial electromagnetic treatment. It is like putting some antennas around the head. In a very, very lay language, it is like putting 8 cell phones attached to your head, and that is electromagnetic type of treatment. The study was published a few years ago. It was quite a good study, actually. It showed that they didn't see too much benefit in terms of those general standard questionnaire, but they saw a decrease in the tau protein. There is hyperbaric oxygen therapy. Some people are saying that it has very good effect, but the studies have been done in very small samples. There is also music physical therapies. They're always effective for every disease, actually. But also there are some insulin type of therapy with nasal spray to the, remember I said this nose is connected to the brain through the window. That's why maybe it is working. There is a nasal spray. I haven't seen a good study with that, but that's an idea, and some people are following up on that type of treatment. What we do at the University of Manitoba is that we try to do diagnosis and monitoring by different techniques, and then using the parallel type of diagnosis to come up with a personalized treatment, to come up that which patient benefits from what type of treatment the most, because not everybody is responsive, for example, to rTMS, not everybody is responsive to TACS. So that's our goal, to come up with a personalized treatment. And these are the treatments that so far we are giving, and I give maintenance treatment, which is repeated every 4 months to people who are positively responsive. And then we monitor them with our assessments, with our own assessments, as well as the physician's report, standard imaging reports, clinical questionnaires, and so on. And of course, there is a back and forth between results of monitoring and changing the strategy. I have changed the strategy of the treatment for quite a number of patients, because keep in mind, these patients are not going to always remain with just, say, pure Alzheimer's. At old ages, almost everybody develops cerebral vascular problems. And having, this is again a hypothesis of my group, saying it, that means that we are not 100% sure, it is just a hypothesis. I believe having some cerebral vascular symptomology mixed with Alzheimer's changes the treatment, require a change in the treatment. That's my hypothesis, and we are working toward that to prove it. We have some recent publication on that, but the sample size has been quite small, in the range of 30, 40. Here are some data talking about sample size, rTMS data in Manitoba. We have had 70, in Montreal there has been 44. So altogether we have had about 130. Australia is another site of our study that they have about 30 as well. So we have about 29 TACs, cognitive exercise, 20 just cognitive exercises. In terms of diagnostic, I'm not going to talk about standard diagnostics because you are probably familiar with them. I'm going to explain what we do. One of them is egocentric spatial orientation test. It's a virtual reality house that looks symmetric from everywhere. I basically designed it based on the administration building of the University of Manitoba. After getting lost in that building so many times, because it is totally symmetric from everywhere, it looks the same from everywhere. So I designed this based on that. So it is exactly the same from everywhere, but except that the front has a door, and we assign a window randomly, and then we rotate the house and ask the subject, where is that target? And when they identify the target, we tell them, okay, go inside the house and find it. When they go inside, they see absolutely no clue. Everywhere looks exactly the same. They have to use their left, right, front, back, respect to where they are to find the target. I have run this test on 378 people. Out of the 378 people, about 30 of them were MCI, mild cognitive impairment, and about plus, on top of that, plus about 70 Alzheimer patients. And I have run it longitudinal, means every 6 months or 8 months, I ask the people to come back and test them again. And I can show you some results. Here are some results. The bars shows the error. in navigating inside the house. From age 20 to almost 90, this is for healthy people. As you can see, the error almost linearly increases by age. But when I had tested Alzheimer's and MCI, mild cognitive impairment, their error was maximum. Basically, they could not navigate inside the house. For those people who couldn't navigate inside the house, I thought I need a different type of test to tell me if they are Alzheimer's, if they are mild cognitive impairment, or what. So for them, I use only localization stage, which is identifying the target from outside the house, just by rotation. It's a very simple test for healthy people. They never make any mistake. But here is the result between Alzheimer's and MCI. I should say Alzheimer's plus other types, although the majority of my subjects were Alzheimer's, but I have had Lewy body dementia, frontotemporal dementia, just 2 frontotemporal, and a number of vascular dementia. If I look at the accuracy, MCI people accuracy is significantly different from the accuracy of Alzheimer patients. Actually, there is basically not much overlap. So this test gives me a good indication if somebody is in the Alzheimer's route, dementia, neurodegenerative route, or it is just mild cognitive impairment due to aging. However, my test does not distinguish between vascular dementia or Alzheimer's mixed with vascular. It doesn't have that capability to distinguish. It cannot distinguish Lewy body either. It can just raise a flag that, hey, be careful. This patient could develop Alzheimer's. And it can say it about, I would say based on my studies, about 2 years before the clinical diagnosis. We have another test, Electro Vestibulography. It is quite a relatively sophisticated test. It has an anechoic chamber, a chair that can move. People sit there, we put electrodes into the ear. Remember again, the other 2 windows to the brain is ear. We put electrodes, soft cotton ball in the ear, and we put them on that chair, and the chair tilts. We measure the vestibular response. Here is the location of the electrode. We don't touch the tympanic membrane, of course. And here is the field potential that we collect from the signal recorded this way. And this signal and the frequency of these field potentials has a capability for diagnosis of neurological disorder. So far, we used it for separating mixed Alzheimer's from Alzheimer's with vascular dementia or pure Alzheimer's. The accuracy has been quite high, 89%. It was accurately identifying people who were mixed from the Alzheimer's. Why is it important? Because we believe that the treatment should be different for these people. We have been monitoring treatment's effect. Furthermore, by chance, actually, we found that this ESG is quite good to predict whether a patient can respond positively to rTMS or not. We did it on relatively a small sample size, only on 28 patients, and the accuracy for that was 76%. It is a very good accuracy, I would say, because we are doing it prediction at baseline, before even we give any treatment, just to gain a little bit confidence. Should we send this patient to the rTMS treatment or not? As for treatment, this is rTMS. That's the coil that I hold over the head. I have permission for this picture, of course. We put the MRI scan on the computer. That MRI scan shows us the skull, and then that works as a GPS for this coil. So we know exactly where we are stimulating. Of course, in this picture, I'm just holding it for the picture. I'm not holding it in the right place for treatment. But based on that neuronavigation system, we give the treatment to where we want to. This is a schematic. This is the TMS machine, which is relatively simple machine. It is a huge capacitor, basically, and give pulses. Is an electromagnetic field. It doesn't give current, it gives pulses, voltage basically, and these pulses, electromagnetic pulses, induces a current inside the brain. How much can it penetrate to the brain? About 2 centimeters at most. So we cannot reach hippocampus. Hippocampus is 5 centimeters down. We reach only the neocortex with this type of coil. There are some other coils that claim that they can reach deeper, yes, but then you are reaching a very much wider area. With this coil that we have, we reach 1 millimeter by 1 millimeter square area. And given that we have about 90 billion of the neuron, even with 1 millimeter square, we have perhaps millions of the neurons. This is a simulation to show that where is the center of the coil strength. What it does is that it induces a current. That current excites the neuron. In general, when we are thinking right now, when I'm speaking right now that you are listening and you are learning something new, there is a firework of the activities in your brain. There is actually a beautiful synaptic activities by fMRI that was published a few years ago. I have the video, not in this slide though, that shows it looks exactly like a firework, because every neuron, when it is excited, it gives 120 millivolt signal. 120 millivolt is quite a high signal and high intensity in a way. So this rTMS, what it does is that it excites the neurons that are being damaged by their synaptic connection are being damaged by the tau protein. It excites them. And the hope is what? Hope is to stimulate the brain, stimulate brain plasticity, so that we can restore some of the lost functions by restoring or generating new synapses. We can give rTMS pulses in 2 modes. We can give it at low frequency. If you give low frequency, it inhibits the neuron, means that it suppresses the neuron. You may ask, what good is it? Well, for depression, for those people who have racing thoughts, rTMS is given as a clinical treatment, and they want to inhibit the neurons from too much activity. That's why that some protocols give that frequency. In our Alzheimer's treatments, we want to excite the neurons, so we give it high frequency. In my team, we give it at 20 hertz. 20 hertz means 20 pulses per second with a train of pulse. Okay, so we talked about frequency. How many? Well, in current study, we give 1,500 pulses in each session, 750 to the left dorsolateral prefrontal cortex, 750 to the right one. The treatment dose is based on the duration of the treatment. We do 2 weeks and 4 weeks every day. Some other groups have investigated 3, 6, 12 weeks every day as well. Target area, we give it to these 2, dorsolateral prefrontal cortex, because prefrontal cortex is the boss of the brain, has the most number of projection of the synaptic connection to all other areas of the brain. And basically we are going after the boss. We hope that if we stimulate this area, we can evoke brain plasticity. And exactly because of the same reason, that's why that I have a hypothesis that if a person has vascular issues in the frontal lobe, they may not be good for rTMS treatment. But that has not been proven, it's just a hypothesis. Writing was just what I said about how we hope it works. Our protocol is multi-center, as I said, Canada, Australia, randomized, double-blind, placebo control, 2 weeks or 4 weeks, active or sham. People who receive sham, we give them real treatment for sure. And people who respond positively, I give them maintenance treatment as well. We do monitor the patients every 2 months up to 6 months with a standard questionnaire, as well as in Manitoba, as well as ESG, as well as egocentric spatial orientation. Another treatment that we do in our lab is TACS, transcranial alternative current stimulation. You're probably familiar with TENS. When you go to a physiotherapy, they give you an electric current to your muscle for your muscle pain. It's similar to that. We put 2 electrodes over the head, left and right, a nodal I give, and it gives a very low level current. It's harmless, painless. Some people find it a little bit annoying. We don't give them to them. It's like a tingling effect on the scalp. It is a low current. It's just 1 milliamp. Remember I said when our neurons are excited, how many milliamp they give? 120 milliamp. 1 milliamp cannot excite a neuron. Absolutely not. So it is not excitatory. All it does is that it stirs the pot. You're boiling something, you're stirring it, letting it to be excited a little bit better. So it does an modulation for the excitability of the neuron. It doesn't directly stimulate. I do use 40 hertz. You can give it at different frequencies. I use 40 hertz. Why? Intuitively, because 40 hertz is the frequency that our brain develops when we are learning, when we pay attention. Type of application could be cathodal or anodal. I put positive here on the left, negative on the right, and amount of current 1 to 1.5 milliamp peak to peak. Again, I'm going to skip this writing. It is talking about the mechanism of the TACS, how it affects. In lay language, all it does, it just makes the neuron to be a little bit more excitable. So since it doesn't excite directly, I pair the TACS with cognitive exercises. Because cognitive exercise for sure is exciting the neurons. Your neurons right now are being excited massively, massively. You have a firework in your brain right now. So I pair it with cognitive exercise. So about the cognitive exercise, some people have questioned it because we know the phrase that use it or lose it. They apply to muscles, right? So the question is, can it be applied to the brain? There are some people that have put a doubt on it, especially this gentleman in, I think it's Case Western University in Ontario, Bobby Stujanski. Bobby, let me call him Bobby, it's much easier to call, he's a colleague. He published a paper in 2018, exactly at the same time that I was about to finish my study on cognitive exercises too. And he said, absolutely, cognitive exercise does nothing. It is all fiction, and it doesn't make people any better. It doesn't have any effect on healthy nor on dementia people and so on. So, yeah, of course, I don't give up easily. I continue the study. And I was saying that my mode of delivery of cognitive exercise is different. And that is the key point. It's important how you design the cognitive exercise, how it is being delivered to the patients. So we developed an app. This app is available for iPads right now. It's called Mind Triggers. It has 7 games. Not that I would say brag about it, that it is all novel. No, some of it is there already. 2 of these games is just novel. I designed it, I like them. But the rest are very much same as many other games on the internet too. Anyway, These are just some samples of the game and the spatial room. This one I particularly like because Alzheimer patients lose their spatial orientation. This is a game that enhances a spatial orientation. So we had two groups we have had since 2018. One group received only cognitive exercise. The other group receiving, because it's still running, cognitive exercise plus TACS. We do it every single day in 2 sessions of half an hour each with the help of a tutor, one of my assistants that I trained for this job. And we measure, so we do it every day for 4 weeks in a row. And then we assess them with a standard questionnaire and other assessments that we have too. And here, for the sake of time, here are some results. Graph is always much easier to see the result. Here is the baseline, post-intervention, follow-up means a month after the intervention. Orange is the one who received only cognitive exercise. Blue are the ones that were paired with TACS simultaneously. You can see that both groups from baseline to post improved significantly. It was statistically significant. Both groups more or less kept the same improvement that they had even a month after the end of exercises. However, the group who were paired with TACS, they were even a little bit still better a month after. In this graph, you can see the difference even better. At post-intervention, the two groups were similarly improved compared to the baseline. This is only shows the changes from the baseline. And then follow-up, people who received TACS in addition to cognitive exercise, they improved even further. So the conclusion was that application of the TACS paired with cognitive exercise, it is better. It is really, yes, makes the neurons to be more excitable and it improves their excitability. And also more than 90% of people were positively responsive. That 10% who didn't, they neither improved nor declined. The study has been published last year. Here is the main conclusions that non-pharmaceutical treatments seem to be more effective than medications. Some patients respond to rTMS well, while some other people don't. Most people respond positively to TACS, but cognitive exercises are important too. But the key is the mode of delivery. You have to take them, give it with a trainer, not to leave them alone with a cognitive exercise and say that do it yourself. It is like you go to gym. Do you need a personal trainer? Would you get better results or not? Obviously, you get a better result when you have a personal trainer. So I would strongly say, yes, use it or lose it. Exercise your brain regularly. Everybody, you don't have to have dementia to do that. To combat the aging effect, we need to exercise our brain on a daily basis. And the key point is to keep it dynamic and challenging and every time make a higher goal for yourself to reach. Last but not the least, I have received funding from NSERC, Riverview Health Center, Western Brain Institute for that large rTMS study. And of course, people's donation have been very, very generous. And I cannot thank them enough for that. And also thanks to our wonderful volunteers. She was my very first patient and that was her birthday. And the reason I put 21 because she was always telling me that she was 21 years old, not more. She was 82. And that left is my mother, who was my inspiration, and her Alzheimer's. That's her picture. About 7 years past the onset of Alzheimer's. And also, I have a wonderful team of young fellows, volunteers who always help. Thank you for listening. I would be glad to take questions. I see some questions on the chat.
Thank you, Dr. Moussavi. Do you want to stop sharing your screen so then we can see our faces? Perfect.
Sure.
Thank you so much for that presentation. There's lots of questions in the chat that Nin and I will ask you. I'm just wondering right now, so right from the beginning of your presentation, you said that the medications for treatment for dementia are less effective, if not very, very minimally effective. So I'm just concerned that a lot of people are going to hear this and call their doctor if they can get a hold of them today and say, we should go off these medications. So how would you address something like that?
First of all, I'm not a physician. I'm an engineer, okay? I know my limitation. What I said was quoting the paper. There are a number of papers. Everybody can read it. They are publicly accessible. Just Google Aricept papers and see what is it. I was quoting the one in 42 is the drastic effect of people response to Aricept compared to sham, compared to placebo, in a very large cohort study, very large studies. That's how they got FDA approval. People get the medication with the hope to be one of those 2.5%, and that there is nothing wrong with it. It doesn't have severe side effects. Some people have side effects, they discontinue, but some people don't have side effect, they keep doing it. 2.5% was for significant improvement. For moderate stabilizing was about 30%. That means 30% of people get a moderate stabilizing effect. Whether that wears off after a year or so, there are not many studies on that. If you're asking my observation, I would say yes, it does. My mom was also on Aricept for a long, long time. I discontinued it for her after a few years. In our study, rTMS, we ask patients not to discontinue their treatment because that can affect our results. So every single patient in our studies have Aricept and they keep doing it. I don't want them to discontinue because it will change our study results, right? If they are not on Aricept, fine. If they are not on any medication, fine. But if they are on medication, we ask them not to change. So it is a personal choice, I would say. If you see some benefits, keep doing it.
Okay.
Not,
thank you.
Yeah.
How do, you mentioned that you have an office for your rTMS treatments in Montreal.
Yes.
What is the criteria for someone to be part of those
it has the bottleneck is that we need a full diagnostic report from either a neurologist or a psychiatrist. That's number one. So if the patient hasn't seen a neurologist or psychiatrist, that's the first step. The family doctor should refer them to a specialist. And then once they are being seen by a specialist, this is the most bottleneck of our study, the longest period. But once they have that diagnostic report, they should send it to us, to my co-PI at Montreal, and we see it. If the diagnosis is written as the Alzheimer's or mixed Alzheimer's, we accept. Other types of dementia is excluded. Vascular dementia excluded, Lewy body excluded, all other types are excluded. Only Alzheimer's or mixed Alzheimer's are included. And then there is an age range. We admit 55 plus to 95. And they shouldn't be on any They shouldn't have any major psychotic disorders. They shouldn't have a history of seizures, epilepsy. There are a long list of exclusion criteria too. But you can send me an email. I'll connect you with my co-PI. Her name is Dr. Lisa Koski in McGill University.
Okay. Is there a chance that you can send that to us and we can send it out to all of the attendees? That would be fantastic. I think that would help everyone
sure,
who's
definitely.
curious about it. Nin, do you have a question?
Yeah, there were a couple of questions asking whether the equipment or technology you use in your study can be transported to, say, medical clinics or residences.
The spatial orientation, definitely, it is just a program, and virtual reality is extremely easy. I have developed even a guideline how to do it and so on. But ESG is not portable. But as I said, Laval University, we are building it for them. Laval University in Quebec is establishing one. The goal of my colleague there is Pierre Maquet. His goal is to apply it to schizophrenia because ESG is also very sensitive to detect schizophrenia separated from depression or bipolar depression. However, once his lab is running, it can easily be used for other purposes too. I believe the lab will be functional within the next 4 to 6 months.
Okay. Thank
Otherwise,
you.
we can come to Winnipeg.
And some people wonder, I mean, these trials, is there ones that you specifically use, like depending on the stage of the disease? So we have people who are wondering about, well, would this be used in Montreal's long-term care settings? Is there a point where the focus should be on one type of treatment versus another?
I would say yes. Again, this is my, if you notice, I didn't say any result about the rTMS study because we are not at liberty to disclose it. But I can share with you my general observations about that. The study is still going on. It is the last year. Probably by the end of the year, we close it completely. Whether we open another one or not depends on the funding. But my observation is that rTMS is not effective if somebody is at advanced stages. Momentarily, it could be. By momentarily, I mean, sometimes I have seen a moment of clarity in some advanced stage patients. All of a sudden, it is like an avalanche of the memories come back to them. They recognize their children, they remember their names, and so on. But unfortunately, it doesn't last long. However, mind you, when my mother had Alzheimer's, which made me to establish all of this, my wish was to see my mom even 10 minutes the way she used to be. So I did it only just to see my mother 10 minutes the way she used to be. So I think that 10 minutes is rewarding for family members sometimes. So it may worth the trial. However, it is so, the protocol is so demanding and it is difficult. They have to come to our to every lab every day for 4 weeks or so on. So generally, if somebody is more advanced stage, I wouldn't recommend rTMS. I would recommend TACS and cognitive exercise, as long as they can understand some simple instructions. If they are gone to a stage that they do not understand a simple instruction, then unfortunately, at least I haven't seen anything to help. Anything other than music, dance, that's good, shouldn't give up. But none of our efforts, I have had advanced stage Alzheimer's that I spend days with them on a daily basis myself, desperately trying to make them a little bit better. Yeah, they get a little bit better this much, but nothing long lasting. So in care homes, depends on the stage. If they can understand a little bit, they can follow some instructions. Yes, there are some hopes. I'm doing it right now in Edmonton, actually, remotely. They are using my Mind Triggers app. They bought a TACS device. I am training their people remotely. I may travel to Edmonton for that too. And then they are running it on their residence. So yes, it can easily be run in any care homes. And the people who are doing it in Edmonton, they are actually a company that develops care home residents.
Thank you for sharing your experience. There were some questions asking whether the app for cognitive exercises is available to the public, and if not, do you have any other exercises that you recommend?
Yes, that Mind Triggers app is public, is on iPads, however. It works only if you have a relatively new iPad. New, I mean iOS 12.4 above. It doesn't work on iPhones or tablets. I'm working on it to develop for Androids and tablets too, but developing apps are extremely expensive, extremely, and I don't have funding for that. So I use the students work. It takes time. But aside from those, I have some free exercises online too. I can send the links to you, or send me an email. I will go through the chat questions if we are running out of time later, and I try to answer everything. I'm just one email away. I'm glued to my emails. It is zahra.moussavi@umanitoba.ca. Send me an email and I'll send you the links.
Yeah, so at the end of the presentation, after I receive an email from Dr. Moussavi, I'll send out the link to the registrants.
Sure, I can type my email in the chat too. Okay.
Can I ask Dr. Moussavi, I saw the images of, with your clinical trials, like all of the images of the devices on the head and so forth. How do people living with dementia respond to having that on those devices kind of on their head or being put there? Because I can only imagine, I mean, it must be weird and awkward, and they might not know what's going on and want to take it off. And so can you talk a little bit about that?
For sure. And while you were asking, I saw two quick questions too. Somebody asked Manitoba Brain Injury Association. I don't know if there is such an association. No. My group doesn't have a name. It is at Riverview Health Center. It's a lab. I have a research lab. And another person wrote, cognitive exercises are proven to be not effective for dementia. That proven, I refer to that Bobby's paper and some other papers. My study proves that yes, the sample size are not great, but my emphasis is the way the exercises are being delivered. If you give an exercise to your grandpa, grandma, I don't know, you to your dementia patient and say that, go do it. No, it is not effective. Absolutely not effective. We do tutor them. You call it placebo effect? Maybe. I'm investigating against placebo as well. Sorry, Megan, back to your question. How they tolerate. rTMS, we have had about 15% withdrawal from rTMS. The withdrawal reasons, some of them hate it, yes. rTMS is a little bit harder to tolerate than TACS. It is like a woodpecker poking to your head like this, and it is a train. 750 pulses. So it depends on the skull thickness. Some people who are petite have a very thin skull. They may find it painful. They may get some facial twitches. Depends on the thickness of the skull, and they may not tolerate it. But the tolerance, as I said, 85% tolerated it quite well. With some complaints, rTMS gives them a headache, but the headache goes away as soon as the pulses are being stopped. Some people never have it feeling at all, but some headache is common. It doesn't need usually aspirin or Advil or anything. It just stops as soon as the treatment is stopped. And we never saw any serious adverse effect. We are very diligent in marking every single adverse effect too. People come, for example, say that, oh, we had a nightmare last night. We write it as an adverse effect. Whether the nightmare was related to the rTMS pulses or not, I don't know. Nobody knows, but we write it then too. But anyway, it is mostly 85% tolerated well. TACS, more than 90-95% tolerated. I myself am a person who I'm not tolerating well actually these things because I have a very sensitive scalp, and even if my glasses are heavy, gives me headache. This is that sensitive. rTMS gives me definitely big headache that I have to take pill for it. I'm speaking about myself. TACS, yeah, that gives me headache too. But I haven't, our patients never reported headache for TACS. I have had a patient who said, not at all, I'm not going to tolerate it. So we discontinued. There were other people who could tolerate, but they said it's, when they are receiving it, they cannot focus on the exercise. So we stopped giving them too, because that defeats the purpose. But in general, as I said, more than 90% tolerate it very well. They don't even feel it.
Okay, thank you. Thank you for that. And it looks like Dr. Moussavi, I want to say thank you. You've enlightened us on all the, alternatives for interventions, and we will be sure to send the necessary links and information once we receive them from you. So for all of the attendees today, please rest assured that we'll do our best to do that. And again, if you have any questions, we can try to get those answered for you. So thank you so much for attending today's lecture and presenting. Tomorrow we have our final lecture in our series at 11 o'clock, where Dr. Michael Hornberger will talk about dementia risk reduction. Again, AGI provides services for everyone living with dementia and their families. To find out more about our programs, please visit our website at agiteam.org, and don't hesitate to contact us if you require more support. So thank you very much, everyone, and I wish you all a good snow day outside. Take care.
Thank you. Bye.
Bye-bye.
Thanks for the invite.
Thanks. Bye-bye.
Bye.